Our next speaker is Dan Doleys. Dan's director of the Doleys Clinic, Pain and Rehabilitation Institute in Birmingham. He did his Ph.D. at the University of Miami and clinical fellowship at the University of Georgia. He's won awards. He's author of Dynamics and Complexity, author of Pain, Dynamics and Complexities. He's also author of Understanding and Managing Chronic Pain, a guide for patients and clinicians. He's highly respected in the pain community on a lot of these meetings that you see. He's a speaker, and he's going to speak this morning on it's actually a little bit the psychology and of pain.
I appreciate the opportunity to come and speak to this audience. It's not one that we in the pain industry have a chance to do, and part of my talk is going to be somewhat philosophical, the other part of it practical, so hopefully there'll be some reasonable takeaway messages. And I entitled this Psychology of and Pain because there's a psychology about approaching pain, and most of my comments are going to be related predominantly to chronic pain. They may have some relation to acute and cancer, but mostly to chronic. So I am on the Speakers Bureau for Medtronic, and these are the goals. We're going to talk a little bit about pain types and mechanisms. I'm not going to spend a lot of time on that because I suspect this audience is very aware of them, but they will have some relevance to some additional comments. And we know the difference between acute and chronic pain. Now, part of the difference between the two has been that chronic pain patients have been said somebody who has had pain that has lasted 3 to 6 months or has outlived the time of the pathology. And I will show you in a little bit that I think that is probably not true. We generally categorize pain as nociceptive pain, that is bone tissue damage, neuropathic pain, inflammatory pain, which I know you've heard a good deal about in recent days, and then fibromyalgia or central amplification. Now, this is something that is very familiar to everybody who has spent any time studying, and this is the classic example of on the diagram for pain. Something happens in the periphery, there are messages that are passed along into the cord, and then the information goes to the brain. Unfortunately, with much of this is where the emphasis is. And even in this diagram, we see the hand being substantially larger, and this is where the emphasis is. There's little talk about what happens here and what happens here, and from a chronic pain standpoint, that may indeed be where the action is, if you will. Elliot Crames in Pain Medicine, an issue from the American Academy of Pain Medicine, did a very eloquent article looking at what goes on in the dorsal root ganglia. And Elliot talked about genetic changes, ion channel changes, microbial changes, nerve growth factor. The interesting thing, again, about this is the discussion of pain as sort of being related to and influenced substantially by what goes on in dorsal root ganglia. Now, no one would argue that this is not an important area, but the question becomes one of whether or not we interpret that as the, if you will, source of pain. There has been recent work, and this came out, and I put this as my title, but they talk about pain in a dish. So Clifford Wolf and his people up at the Stem Cell Center at Harvard have taken cells, skin cells, and through a variety of manipulations have turned them into nociceptive sensing cells. And so the comment in the paper and in the media was pain in a dish. Now, the question here is, are we disembodying pain? Are we, by getting so caught up in Newtonian physics and the notion of materialism and reductionism, taking the patient out of pain, taking the human being out of pain, and we're relegating pain to what happens in the periphery, what happens along these transmission pathways? And I'll make this case that I think that we are, and that may not give us a very complete picture of the nature of pain or chronic pain. So when one looks at, and I enjoy these conversations with anesthesia colleagues, they talk about pain generators. I would suggest to you that if a pain generator, especially in the setting of chronic pain, exists, it does not exist in the periphery. The periphery is a source of information. It is a source of nociception. Now, the danger is if you're talking to a patient and they happen to have some sort of damage to the nerve or the cord or something of that nature, and you tell them this is your pain generator. And in the setting of pain, we're very common to